We will begin momentarily. Good evening, everyone. We are pleased to welcome our faculty for today, Mr. Felix Emeka Anyam, a seasoned research data expert, data scientist, and biostatistician. He is also a member of the editorial board at PLOS1, bringing a wealth of experience in scientific research, data analytics, and publication standards. Without further ado, Mr. Anyam will now begin his session.
Yeah, good evening, everyone. I hope you can hear me clearly.
Yes, we can hear you.
Okay.
Yes, sir, we can.
Okay, so I'm not clear on how the slide is going to change. Is someone controlling it manually or it's also automated?
We will control it manually here, sir.
Okay, thank you. So we'll be looking at study design. So I have been introduced to the session in terms of my bio and my background. Thank you very much. So we begin with the next slide. Okay, so when it comes to study designs, I want us to appreciate something, that the whole essence of study design is not standing alone. It comes from a component of research, which we have to appreciate. You know, research in itself, it's systematic. It has a format, it has a code, it has a pattern, it has a process. The moment you say you want to do research, you have to follow that pattern, you have to follow that process. Okay? Now, one of the processes that you have to follow is, first, you have to choose a design for that study. You can't just say, oh, I want to do anything I like. No, there are laid down principles on how you can carry out that study. And different aspects of the study design has its pattern, the way it flows. But one thing about a study design, apart from the fact that it is a research study method, means that it's a method that guides your research. Most of the research we do in terms of biostatistics and epidemiology has two aspects of it. There would be an exposure and there would be an outcome. If you check your study, majority of the study we do in the health field, in the epidemiology field, and some other field, you are looking at an outcome, which is caused by an exposure. For example, if we talk on the study on noise-induced hearing loss, the exposure definitely would be excess exposure to sound pressure levels that are damaging or that are above the WHO recommended level, which is 85 decibel for a longer duration of time. All right? Whatever it is, if you talk about the prevalence of malaria, which is an outcome, you will definitely be talking about an exposure to the malaria parasite from the mosquito Anopheles. So most of the study we do where we are looking for an outcome, And most times that outcome is a problem, and we're doing that research to solve a problem, we would be looking for what that person, that participant, that patient is exposed to that resulted to that outcome we are interested in. And where you place the exposure and the outcome is what determines what study design you would be using. So when you have this in mind, it's easy for you to say, oh, I think because the exposure is here, the outcome is here, I think this is the best study design for this study. So we'll move to the next slide. Thank you. So, for example, look at this, the impact of climate change on human health in the United States, for example. All right, look at this diagram here. Two things will strike you: exposure and health outcome. The first one says elevated temperatures, the health outcome is health-related death and illness. So if I'm doing a study right now, my interest would be in health-related death and illness and not necessarily elevated temperature, because you are looking at an outcome. Most studies will look at outcome. Then you now begin to look at what exposure that led to that outcome. So the second example, the exposure here is the worsened air quality. That's the ozone, particulate matter, and higher pollen counts. What is the health outcome here? Premature death, acute and chronic cardiovascular and respiratory illnesses. All right. So you would see that exposing themselves to worsened air quality will result to premature death. All right, and also acute and chronic cardiovascular and respiratory diseases. The same thing with contaminated water and as a form of exposure, which will lead to an outcome, apart from drowning, injuries, mental health consequences, and even gastrointestinal illness, sometimes diarrhea and the rest of them, cholera and so forth. Then the final one here, earlier and geographical expanded tick activity, which will lead to Lyme disease. So there are many other diseases that can be caused by different form of insect bites and the rest of them. So this is like an example of how an exposure could lead to a health outcome. And where you put the exposure and the outcome is what gives us the various study designs that we will be talking about now. Okay, so look at this diagram, which is, gives like a simplicity of what is happening. So you look at the types of study design. There are two major types. You have the experimental, then you have the observational. So in the observational group, we'll be looking at the cohort, we'll be looking at the case control and the cross-sectional. Ecological are usually population-based, all right? Ecological studies are not focused on the individual. They are focused on population, more like a country, all right? Then when you talk of experiments, in our field, we have the randomized control trial, which is usually the gold standard, but you can have other form of experimental, like the quasi-experimental, which is a forced experimental kind of design. Quasi means force. So it's not a true randomized control trial, because in a quasi, you don't really necessarily expose the participant to any form of medication or drug, which happens in a true randomized control trial. So it's called quasi because sometimes the exposure can be like an intervention in form of lecture, so that's why it's called quasi experimental design, like a forced experimental design. So these are some of the study designs we'll be looking at. So we will begin with cross-sectional study design. Now, what makes this unique, which is oftentimes carried out, mostly, especially in our setting, because it's quite easy to do, and also the financial burden is usually minimal. So most studies you would find they are cross-sectional study, and they are usually studies where you are looking for an outcome. But that outcome you are looking for is inside an exposed population. So in a cross-sectional study, you find a cross-section of a population that is exposed. So the outcome, that is exposed to the condition that will lead to an outcome you are interested in. For example, the example I gave, which is the noise-induced hearing loss. If you want to do a study on noise-induced hearing loss, which is an outcome you are interested in, definitely you will have to find a population that is exposed to loud sound. Probably those that are musicians, probably those that work in nightclubs, probably those that work in the airports. All right. So for you to do a study on noise-induced hearing loss, you have to take that cross-section from a population that is exposed to loud sound. So most cross-sectional study, if not all of them, are prevalence studies. For me, when my students tell me that they want to do a study that is a prevalence study, oh, I want to look at prevalence of malaria, I want to look at prevalence of preeclampsia, I want to look at prevalence of fibroid, automatically it's a cross-sectional study, because you want to count the number of persons that have the outcome you're interested in a cross-section of an exposed population. So that's what the cross-sectional study is all about. So anytime you want to know the number of participants that have an outcome in an exposed population, you know that is a cross-sectional study. Or anytime you want to do a study where you'll be looking at prevalence of stroke, definitely you'll be looking for prevalence of stroke in a population that is exposed. You will not go and look for prevalence of stroke amongst kindergarten children, or doing a study on the prevalence of stroke amongst secondary school pupils. You may likely not find anything. You know why? Because secondary school pupils are not your exposed population. For you to get the real outcome, you have to go to the population that are exposed. I remember a few years ago, some students, they were doing a study where they are associating, waist circumference with hypertension. And they did that study, and the study didn't come out well. Because majority of what is found in the literature will show you that there is usually a significant association between waist circumference and hypertension. But their study was almost looking different from what literature is saying. And sometimes it's not a good thing to be doing a study that does not align with literature, because literature is supposed to support your study. You can't be in A and the literatures you're reviewing, they are in Z. It's not a good trait. So the students came to my office wanting to know, why that disparity. And I was looking at the data and trying to analyze, and it's looking the same. And I asked them, because the data they gave me, the part they gave me didn't have the social demographic characteristics. And I asked them, who did you collect this data from? And these are medicine students. And they said they actually gave the questionnaire and collected the data from their colleagues. Now, that is easy to do. That is what we call convenient sampling. Of course, it has a lot of error, where you collect data based on comfort. But their colleagues, these are young medical students. So you're doing a study on hypertension and you're collecting your data from majority of the people are below 30 years. That's the wrong population. So for you to get the right prevalence of the outcome you're interested in, you have to go to the right exposed population. So that's what cross-sectional study is all about. So the next one is the case control study. So in this case, it's not a prevalence study. In a cross-sectional study, like I mentioned, the exposure and the outcome you're interested in, they are in the same population. All you are doing is counting the number of those that have the outcome in the exposed population. A case control is different. In a case control study design, You are interested in those that have the case. It's not like in a cross section where you don't know who has the case. You are just counting. Everyone that you are getting for the case control, they have the outcome you are interested in. So you go for the cases. If you want to do a case control on fibroid, all the case will have fibroid. Every participant in that study will have fibroid. So that's why it's called a case control. They are your case group. They are the people that have the condition you're interested in. So what you do is, in a case control, you now begin to retrospectively look back in time what they were exposed to that resulted to that outcome. Unlike in a cross-sectional study where everything is now prospective, in the future, now, present. In a case control study, you get those that have the outcome, then retrospectively you begin to ask them what they are exposed to. That's why it's a case control study. All right. So you have those that have preeclampsia, which is your cases, 100 of them, preeclampsia women. You now begin to ask them questions so that you're able to know what made them susceptible to preeclampsia. All right. Now, the reason why we have a control group so that we don't make a lot of guesstimates. For example, you want to look at prevalence of malaria, and you have, one of your hypotheses that says that there is no significant difference between those that sleep under insecticide-treated nets and the prevalence of malaria. That is one of your hypotheses. So you have a group, they have all tested for positive for malaria parasite. And you begin to ask them, did you sleep under insecticide-treated net? Yes or no? Did you sleep under insecticide-treated net? Yes or no? So there's a good chance that probably amongst the 100 of the people you have recruited that tested positive for malaria parasite, maybe 65 or 70% of them would have told you that they do not sleep under insecticide-treated net. And you may assume that, oh, if 70% of the 100 of them that tested positive for malaria parasite said they don't sleep under insecticide-treated net, it's probably that not sleeping under insecticide-treated net would have led to them having malaria. Yes, you can say that, but that may be wrong, because you also have to find a population as well that tested negative for malaria parasite. All right? Then you ask them the same question as well. That's why it's a case control study. So you don't only focus on the case and the retrospective exposure. You also focus on those that do not have the case and also their retrospective exposure. That is the only way you can truly tell that them not sleeping under insecticide-treated net is what made them susceptible to having malaria parasite. Because if you have 50, participants that said they didn't sleep under insecticide-treated net and they tested positive for malaria parasite, and in the other group, you also have 50 that did not test positive for malaria parasite, but also did not sleep under insecticide-treated net. That's 50-50. So are you still going to say that not sleeping under insecticide-treated net made them more susceptible to malaria? No, because these two groups have equal number of those that didn't sleep under insecticide-treated net. So that's why in a case control, you are not allowed to use only one group and now make a strong justification on that one group. You have to get the case and the control. That's why you can truly say the exposure that you have identified is the true cause of that outcome. So the slide is it's abridged, like it's not showing in a shareable form. I'm not seeing it clearly. It's miniature. Don't know if you can control that.
sir. Can you see it now?
No, it's showing in a miniature form. It's not full screen anymore. If you can stop
Oh,
sharing and maybe reshare again, I think it may correct it.
okay. Let me try that.
The phone.
I'm resharing it now. Can we see it?
No, it's still not doing full screen.
No,
Yeah,
it's full. You have to touch on it. It's full.
I have to touch on it.
Yes.
Oh, okay, okay. Sorry about that. Yeah, sorry. This is new technology for me. Okay, so we would go to cohort study design now. Now, like I mentioned, for the cross sectional, the exposure and the outcome, they are in the same population. You count the number of outcome, all right, from that population, which gives you prevalence. In a case control study, you take the outcome, the exposure is behind. So in the case control, you have the outcome right now. You begin to ask them retrospectively what they were exposed to. Now, in a cohort, it is different. In a cohort, they don't have the outcome. None of the participants have the outcome. All right. And you, most times, you are responsible for the exposure. In a case control study, 100% of the exposure, you didn't cause it. In a case control study, the exposure was in the environment. Like for those that have hearing problem, you didn't expose them to loud sound. It was already in the environment. For those that came down with malaria, you didn't ask the mosquito to bite them or put them in a room where you have infested with mosquito to beat them. No, it was in the environment. That's why it's a case control study. They already have the outcome. You didn't play a role in the outcome. But in the cohort study, in most of the time, the researcher will play a role in the exposure. And the reason why you're playing a role in the exposure, it's because you want to follow them over time to see whether the exposure will result to an outcome you are interested in. So cohort study oftentimes are called longitudinal study, follow-up study, because you have to follow participants. These participants in the initial stage, they were disease-free. They didn't have any disease. So you have a first group, they didn't have any disease. You have a second group, they didn't have any disease. You expose the first group to a condition that will make them have the disease. The other group, they are not exposed to that same exposure. You follow them over time and see whether they will develop the outcome you're interested in. A good example I can give is my bachelor's degree research, where I used 42 Wista rats, white rats. All right, so they were divided into two groups. The first group, I gave them different doses of an extract of a plant called Phyllanthus amarius. In Nigeria here, we use that plant for treating malaria. People drink it to treat malaria, and it's very effective. It works. Okay, but what has not been studied really is the dosage. The dosage. But people that take it, it works. But the dosage, sometimes people don't know how many doses to take. So I did a study where I exposed these rats to different doses of this extract. While the other group of rats, I was just giving them water. And I followed the rats over time. I think it was almost 6 months. And I was dissecting them at different quarters or different intervals. What I found out is that for some that were exposed to lesser doses of those extracts, they died. Because I was checking how that extract, if that extract will result to histopathological changes in the liver of those rats. And that was what happened. So the histopathological changes increases as the dosage increases. So for those that had mild doses, they had histopathological changes. But over time, the liver heals itself and the liver became normal. But for those that had very lethal doses, they died even before I had the chance to even, so they died. So we checked their liver. Yes, they had a lot of damages. So that's what a cohort study is like. You expose them, you follow them over time to see whether they will develop the outcome. That's why you see most times in a cohort study, they would carry it out on animals. I mean, imagine you doing a cohort study on cancer, lung cancer, and you want to expose a group of people to cigarettes, where you say, group A, please smoke 10 sticks of cigarettes every day for 3 months. And you say, group B, please just drink water, don't smoke anything. And you follow them over time for 1 year, 2 years. And after 2 years, you now run some radiological and all those tests they run on their lungs to see whether the group that was smoking 10 sticks of cigarette a day would have had lung cancer. I don't think there's any ethics committee in the world that will approve that kind of study. So most cohort study, you will most likely see them being done on animals, okay, unless it's a retrospective cohort study where possibly there was an environment that had some issues with exposure that is caused by some government or the rest of them. Like in my city, there was a time we had this excess exposure to soot. My city, River State, Port Harcourt, because this is more like the oil, city. So we had these artillery refineries that did a lot of, a lot of refining and the rest of them, and it caused a lot of soot in the atmosphere. And that period, some of us that did studies, that worked with those that did studies, there was a high increase of respiratory tract infection among children. So that is like a retrospective cohort study. The exposure has been there. So you are now following up, these children to see whether they will develop respiratory tract infection. So that can also be a cohort study, but retrospective now, because you are following up the exposure. You started following the exposure, had been there before you came in. So you're following up the exposure and looking at those that will probably develop the outcome in the future. All right. So that is what a cohort study is. So for a cohort study, the exposure is now, the outcome is in the future. For cross-sectional, exposure and outcome is now. For case control, the outcome is now, the exposure is before, retrospective. But in a cohort study, the exposure is now, but the outcome is in the future. Now, why I had to put this table is sometimes when we're doing a case control, a cross-sectional, and a cohort study, we are not sure what contingency table to use. It is usually recommended that if you're doing a cross-sectional study and a case control study and you want to check for probability of odds, you should use odds ratios. All right, because you were not responsible for the exposure. The exposure was already in the environment. Okay, so you're recommended to use odds ratio. But if you're doing a cohort study, you can use relative risk, because most of the time the researcher is responsible for the exposure. So you can truly say that the outcome you are seeing, the exposure, was responsible for that outcome in a cohort study. But you can't say that for odds ratio, because apart from the things they told you they were exposed to, there are a lot of things that may also be there. Like, for example, when I was doing my study on noise-induced hearing loss, yes, I was interested in those that play music in the church and how many times they play. So the exposure I am interested in is the loud sound coming from the speaker. But you have to appreciate the fact that some of them may be working in the airport. Some of them may have had ear disease in the future. Some of them may be working also in a nightclub where they play gigs. So these things can be confounders as well. So you might not really tell which exposure is responsible for that outcome. That's why it's odds of probability. But for relative risk, no, you are certain what the exposure is, what the exposure is causing the risk. That's why it's relative risk. Why the other one is odds ratio, probability of odds of risk. That's why for cohort study, you can say the independent variable, or for example, if the noise, if the, okay, let's say the example of the Worcester rats, you know, I can truly say that the Worcester rats that are exposed to certain lethal dose of the Phyllanthus amarius extract are 2 times, are 3 times, are 4 times more at risk of pathological changes. But for the case control study, I would say that those that are exposed to loud sound are 2 times or 3 times more likely. So for odds ratios, we use more likely or more at odds, but we don't say relative risk or more at risk. No. Thank you. So for the experimental study design, which, you know, the standard, it's usually the randomized control trial. It's a little bit like the cohort study, but this is how it differs. For a cohort study, the exposure leads to an outcome that is damaging. You see, in the cohort study, there is an exposure, and that exposure leads to an outcome, but that outcome is not a good outcome. It's usually an outcome that is not, you know, well received. Like the one you expose them to the dose of extract, the one they are exposed to suits and all that, and at the end of the day, it will lead to something that is not, you know, good. But for a clinical trial, most times the exposure is like a treatment kind of exposure. So it's supposed to make them better. It's supposed to make them well. That's why it's called a clinical trial. All right. So and there's also that randomization in it. So you have a study population that have a condition. Let's say a study population that has lung cancer. Okay. And you have a new treatment, you know, that you can give, that they said, okay, this new treatment can make them better. You know, so it's a trial treatment. That's why it's called a clinical trial. They are still trying to see whether it will work, whether it will not work. So what they do, they randomize the population. They put some group in A and put some group in B. In those that they put in A, they gave them the treatment. In those that they put in B, they give them usually the normal treatment they give cancer patients, but not the new drugs. Then they follow them over time and see what the outcome will be. For the group that was given the new treatment, probably they would get better. Maybe a higher percentage of them will recover faster compared to the standard group, you know, where they are giving standard treatment. So that's how the clinical trial, almost like a cohort study, if you can see. But the exposure for the clinical or the experimental design, it's usually a drug, and a drug that is supposed to be beneficial. All right, but we are not saying at the end of the day, it will always lead to a good outcome. Sometimes you may give a drug and the outcome may not be good, but the intention of giving that drug is for a good outcome. Unlike the cohort study where the intention of that exposure is to lead to an outcome that is not very good. Okay, but apart from the randomized control trial, which is the gold standard, you probably have heard of what they call the quasi-experimental. That's the type of an experimental study design, but it's not randomized control trial. So for quasi-experimental, you replace the medication, the trial drug, with something else that is not a trial drug. For example, you can do a quasi-experimental where you expose them to lectures, where you expose them to something else, but not drug. So that's why it's called quasi-experimental. Force experimental, okay, but it follows the same process. But another thing quasi-experimental doesn't have is the randomization. You don't have to randomize the group. You just have a group where you probably educate them on something and you follow them over time to see whether that education you've given to them will make them better or will make them stay away from something, that you think they are exposed to. Let's say for example, young people that smoke. Okay, you can do a quasi experimental study design where one group, you take them through online classes on how they can stop the habit of smoking, on some of the other alternatives they can do apart from smoking, while the other group, you don't give them such kind of education. You just give them general teaching on well-being. And after 6 months, after 1 year, you carry out the same trial. Initially, you did a survey, how many of them smoke? But when you did the second survey, you would notice that for the group that had those series of, stop smoking lecture, about 30 or 45% of them stopped smoking after 1 year. So you can say that your intervention was successful. But note that that intervention was not a drug. That's why it's not a randomized controlled trial. Thank you. All right. So this vocabulary is very important, especially, when you are doing, studies, especially your study design. You have to be aware what is your dependent variable, what is your outcome variable, because sometimes it brings confusion. And also, what is your explanatory variable, also called independent variable. In the example that I gave to you, which is the noise-induced hearing loss, noise-induced hearing loss is your dependent variable. The dependent variable is the study interest. That is why you're doing the study. And that dependent variable is not alone. Something, like we say in Nigeria, when you see somebody is doing something great, and you know that this person doesn't have the who is bankrolling, monitoring independent variable is not a standalone. For example, noise-induced hearing loss. Noise-induced hearing loss, for someone to have noise-induced hearing loss, it means that they have to be exposed to something which is loud sound. For somebody to have malaria parasite as an outcome, it means that they have to be exposed to the parasite through mosquito bite. All right. For someone to have hypertension, which is the outcome, it means they have to be exposed to an increase in blood pressure that will lead to the hypertension. So the outcome variable, and another example is diarrhea, contaminated food or water. The same thing with cholera. So you're dependent on your outcome variable. Most times, that's the reason why you're doing the study. But you have to appreciate that it does not stand alone. Something is influencing it, unlike the independent variable that is standing on its own. The exposure, the loud sound is standing on its own. Loud sound is loud sound. Nothing is influencing loud sound. Malaria parasite is malaria parasite. It's from the mosquito. Nothing is influencing it. Okay, contaminated water, the water is contaminated. It's not influenced by anything. Okay, but what it causes, which is the diarrhea is dependent on the contaminated water. That's why it's called an outcome variable or a dependent variable, because it has to depend on an independent variable. Thank you.
Good evening, everyone. So I think we'll take a 5 minutes break before we move on to the next one, which is can you hear me? You can unmute yourself.
Yes, we can, but not so loud.
Okay, I was saying that we will have a 5 minute break before we move on
Okay.
to sampling the next session, which is
All right.
um,
sampling method.
Yeah, it's fine. Thank you.
So we'll resume by in 3 minutes.
Sure.
Currently it is 7:12 in this place, so by 7:15 we would continue.
Fine. Thank you.
And also,
Only
let me use
break,
this
yeah.
opportunity to inform everyone that the slides and the replay for this session is going to be available on Ferrat Academy and also on Ferrat YouTube channel. So, but it is highly recommended you join the Academy because you can post your questions there and the faculty will be able to respond to them. I'm going to post the link to the Academy in the chat, so you can make use of this time to join or maybe after the session has been concluded. Thank you. Okay, it looks like it is time we will continue the presentation now. Thank you for your patience and enjoy the rest of the session.
So welcome again. So when we're talking about sampling method, it's also another process of research.
Excuse me, sir.
You have the study design. You want to do a research. You don't just decide, oh, this is how I'm going to select the people that I want to, to be part of my study. No. The research community has set down, yes. Okay, the research community recommends that we follow a systematic process in selecting our sample, meaning in selecting those that are going to join our study. You don't just make a decision and say, okay, I'm going to pick principles that are processes. The same way there are principles and are processes that are guiding how you design your research. There's also principle and processes that is guiding how you will select the participants that will join that your research. So that's what we want to look into right now. So what is sampling? A sample is a subset of an entire population. All right. For example, you have a population of 1,000 people, but you don't have the capacity to do what you want to do with the 1,000 people. And you make a decision and say, okay, I can't work with 1,000 people, but I can work with 100 out of the 1,000. The moment you do that, you had already taken a sample, because that 100, it's not 1,000, but only a subset of the entire population, which is the 1,000. All right. So sometimes you can hear other terms like the sample size, sample population, sampling unit, sampling frame, sampling interval. So sometimes people interchangeably use these other terms, but sampling is usually the universally used word. So the need for selecting a sample. You know, one thing I would say is it's a huge guesstimate, a really huge guesstimate for you to have a population of, let's say, 5,000. Like in my institution now, the University of Port Harcourt, we have over 4,000 students there. And you want to do a research amongst the 4,000 students. Most times you may take a sample of 200, 300, 400, 500, 600 at most, 700 at most. And from that, your research you begin to make some insulin 600 among the research. It's sampling process, and you pick this number, whatever number you pick through that process, that information is universal. Sorry, I'm hearing that they are not hearing me well this time. Please, admin, could you confirm that? Says I am cutting off. Let me see. Is this better? Is this
Yes, sir.
better? Yes, sir. This is better. Okay, thank you. I had to
Yes,
take
now
off.
you understand you.
Okay, so I had to take off the headphones. All right. So, like I was saying, it's a huge, guesstimate, a huge guesstimate, to actually pick that sample and say it's a representation of the entire population. But that can only happen in a research. I mean, just imagine that you sold the goods to somebody. All right. Maybe you sold the goods to somebody for um let's say 100,000 Rwandan, is it dollar or franc? I have been to Rwanda, especially Kigali. My friend, Professor Mojid brought me. That was last year, October. So I can't remember. Is it Rwandan dollar or franc or something? I'm sorry. Yeah, but I know I spent that money. Yeah, okay, Rwandan francs. Okay, thank you so much for reminding me.
It is
Okay,
called Amafaranga. Amafaranga. Yeah.
okay, all right, thank you. So imagine someone bought a goods from you for like 500,000 of that. 500,000 of that 5,000. Let that 5,000 be a representative of the 500,000. How are you going to feel? That can only happen in research, not in real life. So, which is why I keep saying it's a huge guesstimate. This whole sampling thing, and this whole sample size thing, You know, they said, okay, as long as you systematically calculate the sample and you systematically pick the number, they can be representative, you know. So they have removed that burden of using an entire population from us, because an entire population can be very expensive. Imagining you are doing a research in your community. Imagine how many people that are in your community, and you have to interview everyone in your community. That can be very expensive, and most of the time it is impossible, because the time that probably you went there to collect the data, some of them may not be there, some of them would have gone to work, some of them would have traveled to another town or another county. All right, and it can be time consuming. You can spend months collecting that data. So sometimes using the entire population is not feasible. That's why the research community came up with this easy way and say, if you can take a sample, you're good to go. All right, you're good to go. And they also said that as long as you follow the sampling process, all right, you follow the sampling method, especially the probability sampling method, which I'm going to show you now, there is a huge minimization of any form of sampling error that would have resulted from it. So meaning whatever findings you get, you're good to go. All right. So learning the appropriate sampling to use is key to minimizing any form of sampling error, which is what I want to show us now. So you get your sample from a sampling population. So meaning that, like I said initially, you know, when I was talking about the cross-sectional study, your population is the population that is exposed to the condition, to the outcome or the dependent variable you're interested in. All right, it's not everybody in the population that is eligible to be part of your study. Like the study on noise-induced hearing loss that I did among musicians. If you are not a musician, you are not eligible. It is clear. So I already have my inclusion criteria, which is those that play musical instrument at least for a year. That's one of my primary inclusion criteria. If you don't play musical instrument, you're not part of it. All right. So in understanding your sample and the population that you're going to be taking your sample from, you have to understand the eligible population for taking that sample. It is not everyone that is eligible. For example, you are doing a study on preeclampsia. Exclusion criteria would definitely be males. Okay? Exclusion criteria would be males, because males don't have preeclampsia. All right? And most of the time, women that are not in reproductive age do not have preeclampsia. So you cannot be doing a study on preeclampsia and you are interviewing adolescents. And also those that are not pregnant cannot have preeclampsia, because preeclampsia is hypertension in pregnancy. So already you know your exclusion criteria, those that are not in the reproductive age, those that are not pregnant. So your inclusion criteria would be those that are in the reproductive age between 15 and 49 years, those that are pregnant, because preeclampsia, it only happens to women that are pregnant. So understanding your study population, that's also where you're going to take your sample from. So there is a strong link between study population and your sampling. All right? Thank you. So types of sampling methods, We have the probability sampling and we have the non-probability sampling. Now, for most of us in the academics and most of us in research, they usually recommend the probability sampling because it has less sampling error, much more than the convenient sampling. Of course, there are some instances where you may not be able to do probability sampling. You may not have to do the non-probability sampling, but probability sampling is usually the gold standard because the probability for sampling error is minimal compared to the non-probability sampling. So let's look at them individually. So for the probability sampling, it has a form of randomization. All right, randomization in the sense that you give every eligible participant the possibility of being selected. That's why it's a probability sampling. All right, everyone that is eligible, anyone that is eligible has the probability or the chance of being selected. That's why it's called probability sampling. Unlike the other one, where you don't give everyone the opportunity to be selected. You select based on how you feel. That's why it's called convenient sampling. You just take them because it's convenient. You remember the example I gave you about the medical students that were doing study on hypertension and they were using their colleagues for a study on hypertension. That's more like convenient sampling because it was convenient for them, to use their colleagues. But that introduced a lot of sampling error and it made the research, not even worthwhile. Because at the end of the day, you've conducted a research, but you are not able to talk about it because most of your findings are, juxtaposing what you find in literature. All right. Thank you. So the first one is the simple random sampling. This one is very popular, but for you to use simple random sampling, you have to have a sampling frame. So meaning that every of the participants that you want to use for that study, they are all there. So if you don't have a sampling frame, you cannot do simple random sampling. In other words, if you don't have the entire eligible participants that are seated or gathered in that same place, then you won't be able to do simple random sampling because simple random sampling is having a list of all the eligible participants. All right, then doing more like a ballot, shoveling. Then you now randomly pick the number you need. That's what simple random sampling is. For example, you go to a community, where they are mainly farmers in that community, and you want to check for the prevalence of hemmings amongst the farmers. You know what hemmings is? Especially those farmers that farm without any safety gear on their leg. They may be susceptible to having hemmings infestation. So you go to a community, somewhere in Kigali or somewhere else, maybe in Nigeria or anywhere, one of those rural communities where they are big in farming. So for you to do simple random sampling, you have to get the farmers in that region, in that community, in one place, maybe through a town crier, through an announcement of a particular day you're coming, for that study, and they will all gather. And when they gather, you will give each of them a number. All right? You will give each of them a number and you will duplicate that number. And the duplication of that number, you put it in a bowl and you shake it, more like what they do in raffle draw. You shake it. So when you shake it, you begin to pick. So if you have like 100 farmers that are there, but in your sample size, you've calculated that you're going to use 40 participants. So out of the 100 farmers that you have written their names or written their numbers, you have put in a bowl, because most times in research, we usually like to de-identify the participants. So we prefer to give each of them code instead of using their names. All right. So you put the code into that bowl and you shake, and you randomly pick 40 in the bowl of 100. So you pick the first, you call the number, you put them in the research group. You do the same until you pick 40. So the rest of the 60, will not be eligible, for being part of, because they were not, selected. So that's how simple random is done. It's really easy and straightforward. Okay. However, you can do simple random sampling with replacement and simple random sampling without replacement. How does that work? Now, in simple random sampling without replacement, this is how it works. You pick a participant from that bowl. Maybe you pick participant 10 and you call participant 10, and participant 10 just stepped out. Maybe he or she went to ease themselves. You call participant 10 is not there. So without replacement, you're not going to put that number 10 back into the bowl. You will keep it aside. That's simple random sampling without replacement. So you pick participant 10 and participant 10 is not there anymore. You just keep it aside. That's sampling without replacement. All right. Then you pick the next one. But sample with replacement, you pick participant 10, participant 10, they have gone out. You don't keep it aside. You put it back inside the bowl. You shake again and pick. Probably this time you may pick participant 12 or participant 13. But do you know that for simple random sampling with replacement, you may put participant 10 back in the bowl and shake the bowl again. The next one you will pick will still be participant 10. And you call participant 10, they are not there. You put it back again and shake the bowl. So that's simple random sampling with replacement. But the other one is simple random sampling without replacement. Okay, thank you. Okay, so this one is supposed to be stratified sampling. I'm sorry for the heading. Yeah, it's actually mixed up somehow. So this one is supposed to be stratified, sampling, not the simple random sampling anymore. So for stratified sampling, okay, they are usually in a situation where, okay, it's better now. All right, thank you very much. So for stratified sampling, it's usually in a situation, all right, where if you do your sampling, your probability sampling, you may have one group of the strata more than the other group of the strata. All right, let me give you a very good example. In the military, especially in Nigeria, I don't know how it is in Rwanda. In the military, and when I say the military, I mean like the army. They have more males than females in the army. Close to my home, where I live in Port Harcourt, we have a military barrack. All right, we have a very big military barrack close to my home. Now, imagine you want to do a study in that military barrack. Probably you want to do a study on anything, any aspect of the health condition. Okay, and you take your sample tools into that environment, and you now want to do simple random sampling. Okay, maybe not in the individual, maybe you want to do household sampling. Sample the household and begin to interview the individuals that are there. There's a good chance that for every 10 males that you interview, or for every 15 males that you interview, you will find one female. For every 15 males you interview, you will find one female. So you will find out that whatever study you're doing will be skewed against the females, because they are already very small in that environment. So when it comes to an environment where you have one of the homogeneous group more greater than the other group, you don't just go around and do simple random sampling. You have to first stratify them. All right. So what you do is you will tell the participants in the barrack that you want to do this study, and you will need, the males and the females to, participate. So you will have the males, they will be there. You will have the females, they will be there. So what you do is you will stratify them into, male army group and female army group. Then you will now use the second stage, which is the simple random sampling, and pick the number you need from the males and pick the number you need from the females. So that way you will have almost equal number of the males and the females. So for that purpose, you will not have any gender skewed against the other. That's what stratified sampling is. Another good example is probably you want to do a study on mode of delivery, and you go to the clinic. For those that have delivered, you begin to use, simple random sampling. You take like the sampling frame of all the women that have delivered in that ward. All right. Every day you go there, you take a list or like a sample of all the women that have delivered in that ward. You will find out that at the end of the day, you will have more vaginal delivery than cesarean section delivery. So whatever sample you are getting will be skewed against cesarean section delivery. So for a study that you need both vaginal delivery, both cesarean delivery, so that you will be able to, to check your determinants. You don't have to have, you don't want to have for every 10 vaginal delivery, you have 1 cesarean delivery, which will now skew your data and your comparative analysis may not come out well. So what you do in this case, you have to do stratify first. You have to have a list of those that had vaginal delivery, then have a list of those that have cesarean section. And using simple random sampling, pick the number you need from vagina, pick the number you need from cesarean. I remember I had a chat with a colleague of mine. He's an ophthalmologist, and they went to the prison, to do like an outreach. And what he told me is that the ratio of male to female is 19:1. 19:1. So for every 19 male, there was 1 female. So for them to be able to serve the female adequately, they did the same stratify. They put all the males together and put all the females together. So when they finished doing the simple random sampling, they now had 1.95 against 1. So meaning for every 2 males, they had 1 female. So if you want to do a study where one of the homogeneous group is way more than the other, you have to do stratified sampling first before you now do simple random sampling. If not, one group will be, more skewed against the other. So cluster sample is another example of, sampling. So cluster sample happens when you want to do a study, all right, where you have too many homogeneous but yet internally heterogeneous group in a study. Imagine you want to do a study amongst government-funded public schools. Let's say in this case now in Rwanda. Like in Nigeria, even in my city alone, we may have more than 2,000 government-funded public schools. Even in my Port Harcourt city alone, there may be up to 2,000 government-funded public schools. So that might be the same in Kigali. You may have a lot of government-funded public schools. Imagine you want to do a study, all right, in this government public school. I don't think you have the time. I don't think you have the resources to go to all the government funding public school in Kigali. I doubt you will be able to do that. The number of time it will take, the financial implication. So in this case, they said you can use cluster sampling because they consider each of the government funding public school as a cluster. So I'm not talking about private funding school now. I'm not talking about the private school. I'm focusing on, because the private school is a cluster on its own, while the government funded public school is a cluster on its own. All right. So you have to focus on one cluster that are homogeneous, that are similar. So the public schools that are funded by the government is a cluster. And if you have like 1,000 of them, you can't go to all of them. So what they say is have a list. So you want to do a study in this government public school, you can't go to all of them. All right. And peradventure, you've calculated your sample size, and probably your sample size is like 500. And each government public school maybe holds like 100. I'm just giving for an example. I know it's more than that. I'm just using this as an example. Let's say your sample size is 500 and each government funded public school, all right, holds 100. So what that means is you need approximately 5-6 of these schools, nothing more, and you have 1,000 of that. So you can't afford to go to the 1,000 because you don't need the 1,000 to make up your sample size. You just need like 6 of them. So you do cluster sampling. How? You have a list of all. So you can go to the schools board, like in my own station, you can get that list from the primary schools, from the government primary schools board. They will give you a list of all the government funded public school. Then from that list, you will now use simple random sampling to pick 5 or 6. So that list is a cluster of the schools. So you now use simple random sampling to pick the number you need. So that 6 school that you have picked is a representation of the 1,000. You know, that's why I said these things are a huge guesstimate. So you pick 6 schools, which is the 6 cluster from the 1,000, and that 6 schools, which is able to help you, hit your sample size, will be a representative. If you had interviewed if you had picked your samples from the entire 1,000 public school. So for the systematic sampling, you will often find this in a hospital-based study, because in a hospital-based study, you may not be able to have a sampling frame. You may not be able to have a sampling frame. You know why? Because in a hospital, people don't just come and sit down and wait for the others. So for you to have a sampling, for you to do simple random sampling, you have to have a sampling frame, meaning that you have to have the eligible participant in one place. Then you give them number, put it in a bowl, and now select. In a hospital base, you don't have the pleasure of that. People come, have their treatment and they go. They don't sit down there and wait. So for hospital base, you would most likely do a systematic sampling, meaning that you will choose them as they come. But there is a probability way of choosing them. You don't just choose them like that. So they say, first of all, you have to calculate a sampling interval. All right. So what is a sampling interval? Is where you divide the population size against the sample that you require. For example, now you've calculated your sample. Let's say you are doing a study on preeclampsia now, which is a good study to use the systematic sampling because it's a hospital-based study. So you recruit the women as they come, but that recruitment has to follow an interval. Every first woman, every second woman that comes, or every third woman that comes, or every fourth woman that comes, you don't just make a decision of that. You have to calculate a sampling interval. So you will go to the antenatal clinic and ask them, what is the number of women you usually receive in a day? And they will tell you, okay, we usually have 400 women come in a day. Okay, and you have calculated your sample size of women you need, and the sample size of women you need is 80. It's just 80 women you need. So to calculate your sampling interval, you will do the population that usually comes to the antenatal clinic, divide by the sample size you need. In this case, it will now give you 5. So it means that for every 5th woman that come, they will be included in the study. But to select the first woman that you will select will be through simple random sampling from those that are already seated. So you come to the clinic that morning, you have like 5 women already seated or 10 women already seated. That 10 women that are seated, that's your sampling frame to start with. Then amongst that 10, you do a simple random sampling, you pick your first sample. Then after you've picked your first sample, you start counting. The first woman comes, second woman comes, third woman comes, fourth woman comes. The 5th woman that comes, you recruit them for your study. You start counting again, 1, 2, 3, 4, 5. The 5th, you recruit. So you recruit every 5th person that comes into the clinic. That's systematic sampling. All right? Yeah. So for the probability, I know someone said I should explain the multi-stage. There's a slide for that. So for the non-probability, you don't follow any method. You just do as you like. Okay. The first one is convenient sampling, like the very good example I gave you. It was convenient for the students to use their colleagues. Another example would be that you are doing a study as a medical doctor that is a consultant of a professor, and you're doing a study on probably average income of health workers in a teaching hospital. And you forget that in a teaching hospital is not only made up of consultants and professors. You have the warders, people that help with the patient. If the patient needs help, the warders are there. You have the cleaners, you have the security personnel, you have the lab technicians, you have the radiologists, you have all kinds of people. But because as a consultant, as a professor, you feel that you don't have the time to meet all those people, you now begin to administer the questionnaire or the study tools to only your colleagues that are probably consultants and professors like you. You'll find out that that data will be skewed, because when you analyze that data, it will look like your teaching hospital is the highest paid teaching hospital in that country. Because the only people that feel their paycheck is those that are at a very high level. You didn't go to the baseline to also get their paycheck value. So that's also an example of convenient sampling. You just sample based on how it pleases you. You feel, I don't have time. That's convenient sampling, and it has high sampling error and the bias. The other one is judgmental sampling, where you give your questionnaire or your study tools based on how you feel. For example, a non-governmental organization has reached out to you and said they want to carry out community development project, and they are doing a needs assessment, and they want you to go around the community and get their opinion on what they feel before they will carry out the needs assessment, and you are given the project, and you became judgmental. For example, there is a particular group of people you don't like. For example, like female sex workers, injection drug users, and they have their spot in the community. And you're getting other people's opinion. When you get to the brothels where these female sex workers or all these vulnerable group of people are, you will pass. You will not administer questionnaires to them because you don't like them. You don't like the lifestyle they live. You are judgmental. But you have to appreciate the fact that if they don't also give their opinion, you will not be able to get an accurate feedback of the population needs, because those people are also part of the population. So you have to get their own opinion. So judgmental simply means giving the study tools to the people that pleases you against the people that you don't like.
Judgmental, coordinator. Ndozi nzasubira kwiga. Ninsoza kwiga nibwo nzatangira kwiga.
So the other one is purposive sampling, where you choose the units with a specific purpose or objective in mind. For example, now there was one study we did, which is actually a clinical trial, in 4 states here in Nigeria. My state was one of those states that did that trial. The trial was on postpartum anemia, women that have postpartum anemia after delivery. And some people were randomized to take an intravenous iron solution that will boost their blood over time, while some group were randomized to take the iron tablets that they would take for like 6 weeks. All right. Now, if we didn't use, a probability sampling in terms of randomization, which was done electronically by a company in the US called sealed envelope. So there were those doing the randomization for us and telling us which woman is in group A and who is in group B. We were not responsible for the randomization. You know why? Because we may be tempted to do purposive sampling. We may have an objective in mind. For example, for a woman to be eligible as having postpartum anemia, your hemoglobin has to be 9.9. Once your hemoglobin is 9.9, it means you are eligible. Then the randomization will take place, whether you will take the IV or whether you will take the tablet. The IV is faster. It will boost the woman's blood faster. But we wanted to know which one is more effective. You now, test a woman's blood and now saw that her hemoglobin is 5.5. There are some women we tested. Their hemoglobin was 5.5. But the randomization says she should go to tablets. But if we were doing purposive sampling, we would intentionally move all those women that have very low hemoglobin. We will move them to the intravenous group because we will be sorry for them and we would want their blood to build up faster. So we will be objective in what group we put them. So that's what purposive sampling is. You give people study tools or you put them in a group because of an objective you have in mind, because you feel that their blood hemoglobin is very low, you don't want them to suffer, then you put them in a group where you think it will help their blood build faster. You've already biased that study based on your objective mind. So that's what purposive sampling does. Now, for haphazard sampling, you don't have a pattern, anything goes. You just make a decision who to give the sample, the tool, and who not to give. And in haphazard sampling, you could make an error. Imagine you are doing a study, where your focus, is on adolescents. But because you are haphazard, you start giving people, tools that are not in the category of adolescents. That's what haphazard sampling is. Anything goes. Anything is applicable. Anybody can feel, that is not good at all. So the other one is slow balling, which is not bad, especially if you're doing qualitative study. Like one of my studies is a qualitative study, which I did among female sex workers. And for you to work with vulnerable populations or key populations, you have to depend on snowballing. It's not a probability sampling. It's a non-probability sampling, but it's also good especially if you're doing qualitative study, but not good for quantitative. It could cause bias. But for qualitative, it is fine because you interview one person and you tell them to refer you to another person that would like to be interviewed. That's snowballing. You get your participant based on referral. You interview one, they refer you to another. Like if you're doing a study among MSM, men who have sex with men, it's not easy to find them. Even in Port Harcourt, it's not easy. So you are able to find one. You have to talk to that one to refer you to another person so that you can also interview them. So that's snowballing. Why the quota sampling is based on a particular group, based on the qualities or the trait or the characteristics. All right. A good example I gave here is like a cigarette company wants to find out what age group prefers what brand of cigarette in a particular city. So they will be applying that sample based on quota. Like they will apply it based on those that are between 21 to 30, and also those that are between 31 to 40, those that are between 41 to 50, so that at the end of the day, they will be able to tell which group, in terms of the age group, prefer a particular brand of cigarette than the other. So that's quota sampling. It's not, a probability sampling, because you have to be intentional of the age group you are giving it to. Before you administer the survey, you ask them, how old are you? They will tell you, say, okay, because you are this age, you are qualified. So it's not probability. It is intentional administration because you are targeting a particular group, a particular people that have a particular trait that or quality that you are interested in. So this is the multi-stage you are asking about. What is multi-stage? Multi-stage is simply using more than 2 sampling process. So if it's one sample stage, like if I use the randomized, if I use the simple random sample, it is 1 stage. If I add stratify to it, it is 2 stage. If I now add cluster sampling to that stratified, it is now multi-stage. You see? So once you add more than 3 or more sampling process to be able to pick your participant, it is multi-stage. For example, the example that I gave in school, it can be a multi-stage. How is it a multi-stage? First of all right, you may decide to choose the local government that you want to collect this sample, or the district you want to collect this sample. So you have a sampling frame of the number of districts. And first, you use the first stage, which is simple random sampling, to pick the 1 or 2 districts you want to pick the school from. So that's simple random sampling to pick the district. Now, in that district, you now get a sampling frame of the number of public schools in that district. You now use another simple random sampling to pick the number, all right, the number of the school you need. That's stage 2, but another simple random sampling. Then, after you have picked the school, all right, which you need, you can now go to the school and take a list of all the students in that class, which will serve as your sampling frame. That's another simple random sampling the 3rd time. That's already a multi-stage. As long as you've done sampling more than 2, that's 3 or more, it's a multi-stage. So multi-stage simply means individual, the different type of sampling that I've described. When you have to follow the steps, 3 or more, it makes it multi-stage. So multi-stage is not like a unique type of sampling. It's just simply using the different sampling I've mentioned, 3 or more, because you can do simple random, then later you can now add cluster or stratify to it, now do another simple random, just to be able to meet your population. That automatically makes it multi-stage, as long as it's 3 or more. All right, so this is the sampling process in summary. So like I mentioned, you have to, first of all, Know your target population. Your target population. To whom do you wish to generalize this finding? Everybody is not your target population. For preeclampsia, your target population is those that are women that are pregnant. For stroke, your target population would be adult population, adult and elderly, not children. So you have to know your target population and also your accessible population, your target population, and those that are accessible, you can administer the questionnaires to. All right. Then the inclusion and the exclusion, which I had talked about. Those that meet the inclusion criteria and those that do not meet the inclusion criteria. And if you're going to have a sampling frame, meaning a list of those that are eligible, so that you can now pick your sample from that sampling frame using the different sampling approaches that you want to use, either probability or non-probability, based on your sample size, because it's the sample size that will guide the number that you're going to choose in the study that you want to do.
Okay, hi. Can everyone hear me? You can mute yourselves.
Yes.
Okay. So it
Hear
is time
you.
for the questions. And before that, we thank our faculty for the awesome presentation. I know even me that I'm just starting statistics, I learned a lot from it. And I believe everyone has also learned a lot from this session. So you can ask your questions through the chat, or you can unmute yourself and ask your question.
So, yes, can I ask my question?
Yes, you can. You can go ahead.
Okay, so we really thank the organizers of this program as well as the presenter. I am Hamza Alhaji Abdullah by name from Federal University, Kashire, Gombe State, Nigeria. I really get a lot of information that I never ever forever obtained in my life through this presentation. So I really appreciate the organizers and also the presenter. My question goes like this. Uh, like I heard the presenter saying that using non-probability sampling there is associated with higher errors, but he also recommend the use of snowball sampling, which he say is good for qualitative study. So is it also good to use that snowball for qualitative study, or because the issue of the higher error to be obtained using non-probability sample is a general for all the method, or is not affected snowball sampling? Thank you.
Okay, so I got your message very well. Now, the reason why we don't recommend non-probability sampling for quantitative study is because you will be biased in the way you're choosing your sample. You're supposed to choose your sample in such a way that every person in your eligible population has an equal chance of being selected. But when you do convenient sampling, you will be doing it based on your feelings and your idea on what you think, and that may not be really good. However, you would appreciate the fact that in qualitative studies, it is qualitative because it's not based on number. Quantitative studies are based on number. So they can easily be influenced when you don't do the selection of the numbers well. But qualitative study is not based on number. It's based on quality, based on characteristics that you want to find out. That's why you would notice that in qualitative studies, we don't usually calculate sample size. What we do, we interview until we get to where we have what they call saturation. What is data saturation? It means a point where you get to, and the things that your participants are telling you are repetitive. You are not hearing any new information anymore. If you start interviewing them, you may get to data saturation when you get to the 10th person. You may get to data saturation when you get to the 15th person. You may get to data saturation when you get to the 16th person, and you will stop interviewing. So it's not based on quantity. As long as it's not based on quantity, it's not influenced by sampling error. You see it, it's not influenced by sampling error. That's why we usually recommend non-probability for qualitative, because it's not influenced by sampling error, because quantity, it doesn't deal with quantity, it deals with quality, meaning the thematic characteristics you want to find out. But you will notice that in quantitative study, you're talking about prevalence, incidence. These are numbers, and they can be biased by the how you select the number that will be included in that study. I hope I clarified your query.
Yes, sir. Yes, sir. Definitely, I get it. Then my second question is on the experimental design, which is the randomized sampling. Under that one, I have two questions. Please, precisely, what is the actual meaning of randomization? The actual meaning of randomization, the word randomization. And secondly, the experimental study design that involve randomized controlled trials. So, what is actually that randomized controlled trials? Thank you, sir.
Okay. So first of all, when you say randomization, it means that you didn't just choose the participant. You remember the example of the study I gave you, where we are doing postpartum anemia, women that have postpartum anemia. The randomization is actually done by a US company called Sealed Envelope. You can Google and check them out. So what Sealed Envelope does is that when these women are eligible, meaning that their hemoglobin is 9.9 or below, we send their name, we put it in the database. Sealed Envelope will randomize it and send us and say, okay, this woman is eligible for IV, or this woman is eligible for tablets. That's the randomization. You randomly decide which group, because when you're doing a randomized controlled trial, eh, you don't make a decision for yourself who will join the treatment group and who will join the control group. Now, the reason why it's called a randomized controlled trial is because first, there's randomization. Then secondly, there is a control. So meaning that you don't only have the treatment group, you also have the control group. And it's also a trial, meaning that whatever treatment you're using is not 100% confirmed. You are still trying it to see whether you can validate it for use. So that's why it's a randomized control trial. The reason why you're randomizing, because you don't want your own characteristics to influence who will be given the treatment group and who will be given the control group. You remember the example I gave you? You see a woman that has a hemoglobin that is very low, and you're tempted to put her in the treatment group because you want her to get better. That's not randomization anymore. So if you do that, you are already introducing bias and error into the selection process, or who joins what group.
So, thank you, sir. I really appreciate and I get it. Thank you, sir. We are really appreciated. Thank you.
Thank you. So let me take some questions in the screen. The first one from Emmanuel says, can simple random sampling and two other non-probability sampling methods be mixed as no. Multi-stage is usually probability. I'm sorry, I didn't clear that. When you say multi-stage sampling, it's based on 3 or more probability sampling. You can't miss. We don't usually have multi-stage for non-probability sampling. That multi-stage is for probability sampling only. Dr. Ogemdi says, can quasi-experiment be used in social science research or quantitative study? Yes. Quasi-experimental simply means any experimental study you're doing, meaning that a study that has an intervention to cause a change, but that intervention is not a drug. That's why it's called a quasi-experimental. If you teach people something eh, that will improve their life or will make them better people, it's an intervention, but that intervention is teaching, not drug. That's why it's called quasi-experimental, false experimental. So it can be used in social science and it can be used in quantitative study. Yes, it can. Please, is it reality to use multiple sampling? Yes, it is reality to use multiple sampling, like I've mentioned, especially when you're doing a community-based study where you have to go from up to down. Before you do a community-based study, you have to choose the district first. Like in Nigeria, you want to do a study in a community in Port Harcourt. First of all, you have to decide the local government first. Port Harcourt has several, the River State has several local government. You have to first choose the local government. In each of that local government, you have to choose the community. All right. In each of the communities you've chosen, then you now have to choose the school where you want to pick the sample. In each of the school, then you now have to choose the participant. So you find out that there are stages of sampling. Yeah. Some studies will have multiple stages of sampling, while some will have one. Then Abdul Majid said, my question is, between duplicate and triplicate sample, which one is best? Well, there's no one that is best. It depends on your study. Your study may require duplicate, your study may require triplicates. All right, it depends on the study. And I am assuming that this duplicate and triplicate you are talking about is the sample, not the sample size. I hope you're talking about the sampling method, meaning 1 stage, 2 stage, 3 stage, not sample size. All right. So anyway, it depends on your research, really. Yeah. So any of them is okay based on your research. Can you differentiate case control study to cohort study? Use practical example. Of course, I gave a practical example, when I was teaching. If you're doing let's say now you want to do a case control study for lung cancer. For a case control study for lung cancer, you will go to a teaching hospital. You will get all the folders of those that already have lung cancer that are your cases. Then you will now begin to call them on the phone and ask them questions that would have made them susceptible to lung cancer. Probably asking them, do you smoke before? How many sticks of cigarette do you use to smoke? Do you still smoke now? How many, you'll be asking them things around what would have made them susceptible to cancer. That's a case control. So you find the cases, those that have the cancer, you begin to ask them retrospectively what they were involved in that made them more susceptible to that cancer. For a cohort study, they don't have the cancer in any way. All right? You will now be telling them to smoke cigarettes, and you follow them over time to see whether they will develop cancer, lung cancer in the future. That's a cohort study. You meet the people that don't have the condition you're interested in, you provide an exposure and follow them over time, more like a longitudinal study to see whether they will develop the cancer in the future. That's a practical example. Is there any problem to use probability sampling in qualitative? Well, you will not be able to use probability sampling in qualitative study because qualitative study has nothing to do with number. It has to do with quality. So you can even interview 2 people, 3 people, 4 people in a qualitative study. It's fine. As long as that 4 people has reached your saturation point, meaning the point where they are all saying the same thing and you're not getting any new information. All right. So that's qualitative study. So you use non-probability. And in the non-probability means you have to find them where they are. Qualitative study, you will find them where they are and you meet them and interview them. So there's no need doing simple random sampling because you don't need many people in qualitative, just very few people. So you don't need to do probability sampling. Non-probability is fine. And when you're working with key population, like the example I gave to you, then it has to be snowballing because you may not find them very easily. When you're able to find one, ask them if they know another person that they can interview. Imagine doing a study like intimate partner violence or gender-based violence. You may not find those people very easily, or those that has been raped. You may not find them very easily, but they know themselves. You interview a lady that has been raped, and you ask them, please, do you know another colleague that have been raped that I can interview? That's snowballing. So there are some sensitive studies that you may not find the people out there very easily. You can only get them through referral. Yeah. So any other question? Is that all?
Well done, Prof. I really appreciate the insight you gave us. My name is Taiwo Adiremi. Yes,
All
I
right.
would like to know, if possible, how to calculate the mathematical formula to calculate the sample size, because I think that's very key. That's the need for any researcher to work on. That's in a quantitative research study, please.
Yes, I think we should have a session on sample size calculation. Prof, is Prof here? Professor Mojid, are you here? I think one of the sessions will be on sample size the determination. I think so. Please,
Oh,
if we
fantastic,
can.
fantastic.
Yes, I think so. Yes, and
Then
I will be happy to
I
take
will
that
look
session.
up to that.
Yes.
I will look up to that. No problem. Well done, sir. Thank you.
Okay. All right. Thank you so much. Yeah.
But hello, sir. I
Can
have
I
a
please
question,
go
sir.
next?
I have a question.
Sure. Please go ahead.
Yes. Please, is there any WhatsApp group for us to join this academy? Is there any WhatsApp group, or is only
The organizers will answer that.
Okay. Then secondly, sir,
Okay.
if I
Data collection and measurement. Yes. So did you see that? Data
I've seen
collection
it.
and measurement.
I've
So
seen it.
so part of the measurement would be sample size determination. So I will treat it then if I am the one that would take that session. It's
Okay.
not
Can I ask
qualified
a
yet.
question?
Yes, please.
then
Can I
my
go
second
next?
question. My second question, please.
Yeah.
If I understood the presentation, it means for a qualitative study, the best sampling method to use is generally non-probability sampling for
Of
qualitative
course.
studies,
Yes.
and
It's not probability.
it is allowed.
Yes, of course, it's allowed because you are not dealing in qualitative studies, not based on number.
Okay.
And yeah, in quality, that's why there's nothing like prevalence in qualitative study. It's based on themes, thematic information. So you will not see anything number prevalence in a qualitative study. It's based on what people said. Have you noticed that? It's based
Yes,
on
sir. Yes,
quotes.
sir.
Teams. So you can use non-probability in qualitative. It's fine.
Oh,
Yes.
okay. Thank you, sir.
Thank you too.
Can I also
Yeah,
ask a question?
please go ahead, lady. Yeah.
Oh, thank you so much for the presentation. My question, I need more clarity, specifically on the procedure to follow for the three-stage multi-stage sampling strategy. In my case, my target, I'm looking at the refugee women who are heading households. So I need your guidance specifically on the procedure, how I can combine, first of all, the cluster and the stratified random sampling. Thank you.
So good. So when you are dealing with refugee women now, you know that they are not everywhere. So you will definitely have to use stratified in one stage or the other, meaning that you have to bring the refugee women on their own strata, and
Maybe point of correction.
okay.
I'm using refugee women heading household.
Yeah, so the refugee women heading household in that community now, are they all refugee women heading household?
No.
That is why I'm saying that strata will come in, meaning that if you do normal, simple, random sampling, most of the people you will select may not be refugee women that are heading household. I don't know if you get what I'm saying. So
Yeah, I wanted to combine. I wanted to combine cluster whereby I will select geographically the zones. Then
good.
after selecting the zones, I do the stratified. So I just needed like
Exactly.
clarity.
Exactly.
Yeah.
That is the point I'm saying now. You will definitely do stratify, meaning you will have to bring all the cluster, you have to bring the cluster of the refugee women that are heading household, because that's your interest group. Why you will now have
Yeah.
another strata of the non-refugee that are heading household. But if you just do simple random in that community, most of the people you may select may not be your interest population. So the cluster, yes, but stratified, yes. Then when you have gotten the people that you're interested in, then you will now do simple random sampling to pick, because it's not all of them. Unless you want to interview all of them, then you may not do another sampling stage anymore. It will now be 2 stage. But if you still want to, if the number is many and you want to now use a subset, you will now do another third stage, which will now be simple random, meaning all those people you have identified through the stratified, they will be your sampling frame. You will now randomly
Okay.
pick. So each of the household will have a number. So from that number, you will now pick the number of household that you want. I don't know if that is
Okay.
clear.
Yeah. Thank you so much.
Okay, all right. What method? Okay, the sample size own I have clarified. We would have another session on that. Please, if in randomized design experiment, one of the control is negative and the other two are positive, please, how can I handle this? Can I make use of only two uh, positive? If that is what you found in your study, of course, you can make use of two positive, but I'm not clear on what you mean by positive, because when you're talking about randomized design here, you are talking about a group that have a condition, they have an outcome, but you are giving them a drug to see whether they will be better. So when you say positive, do you mean that they positively reacted to the drug? Is that what you mean? Or they negatively reacted to the drug? Kehinde, can you please, can you verbally, so that I'm clear with what you're asking? Yeah, Kehinde, please unmute yourself. Let me understand you very well. Kehinde, are you here? Please unmute yourself and talk to me.
Okay, thank you, sir. I want
Yes.
to experimental design.
Your audio is breaking.
So, out of that 3 replicates is not, performing negatively, but it's only 2 now that is now, performing well. So
Okay.
that's why
Hold
I'm
on.
asking that question. Can
I
we
didn't.
now?
Kende, I didn't get the beginning. You were not audible. So start again, please. Let me get you.
Can you hear me?
Yes, I can hear you now. Go ahead.
What I'm saying that, in randomized
There.
3 replicates. Control also will also be in 3 replicates. But in this case now, instead for the whole 3 control to maintain the same outcome, only 2 of them give the positive outcome, but the remaining one behave other way around.
I'm still not clear. Your audio. Okay. I don't know. I think is there an opportunity to I'm not your audio. So if you're doing a randomized design experiment, so what are you giving them drug to treat?
Okay, in this case now, it's plants.
Okay, it's plants. So what are you giving the
Yes.
plant?
Okay, in this case now, the plants, we have the one that have the fertilizer, we have the one that does not have the fertilizer, we have the
Uh-huh.
one that have uh the organic fertilizer,
Okay.
and so we have different control like that.
Okay.
So, but meanwhile, for the because we have about three control.
Okay.
We have three control, and that's randomized. We have the one with organic carrier, which
Okay.
is control. We have the one with normal fertilizer, the chemical fertilizer, and we
Okay.
have the one without fertilizer, without anything.
Okay.
Now, eight of them have three replicates,
Okay.
but the one without fertilizer, one of them now. Out of that three replicates, one is not, you know, does not maintain the same status with other plants.
Okay.
So it's giving a kind of positive, negative outcome. So we now have the two positives. So I was now thinking that, can I make use of the remaining two replicates that is giving me a good result, or what can I do?
Yeah. So you have two options. If you use the
Okay.
two positive, it is still fine.
Okay.
You will state
Okay.
it in your research that during the research process that one
Okay.
of them failed, so you use two. It's
Oh,
fine
okay.
because you have to appreciate the fact that when you're doing a randomized control trial, especially for human being, there's something they call
Okay.
attrition. Attrition means loss to follow up, meaning you can
Okay.
start
Oh,
with 10 people now. By the time you finish the
okay.
study, it's only 5 that is remaining. 5 has run away. So will you say
Wow.
you will stop the research because 5 people
Hmm.
not complete? We account for them. We call them attrition, loss to follow up. So
Wow.
that same thing happens to implants. You will continue. You don't have to stop because one fall on the wayside. Eh?
Okay. 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 Thank you, sir.
No
Thank you.
worries.
Thank you. Thank you. I'm very, very grateful. Thank you, sir.
All right. So
Thank you, everyone. We won't be able to accommodate questions anymore. At this note, I thank Dr. Felix for this beautiful presentation and insightful one. We are very grateful for this, and I'm sure we all enjoyed this session. We have spent additional 30 minutes, so we are so sorry. We won't be able to go beyond this. So meet us again next month for another insightful presentation by another seasoned expert, and that will be June 19th. So let's be on the lookout, and we'll be discussing data collection and measurement. Thank you so much. We thank all our audience for answering the call and for them to be here. Thank you all for your support. Thank you. Bye to everyone.
Thank you.
For people that still have questions, or if your question is not answered, you can easily send it in at Firat Academy. You will be answered there. So direct your questions to Firat Academy platform.